We call them distinguished addresses because we are really mindful that the original language of master classes is problematic for the reasons that might be really apparent to you, and because we take an intersectional power analysis, we are also mindful to not replicate power structures that are masculinist, nor which are infused by coloniality. Hence the shift away from talking about masterclasses, and we refer to them as distinguished addresses. And in our distinguished speaker series this evening, we have Dr. Timothy. Roberta Timothy is Assistant Professor, Black Health Lead, and is the inaugural Program Director and creator of the MPH program in the field of Black mental health at the Dalla Lana School of Public Health at the University of Toronto. Dr. Timothy is also the adjunct professor in critical disability studies at York University. She specializes in the areas of Black health, intersectionality, Black children and families, violence, transgenerational trauma, African Black feminism, ethics in health work, health and racism, art-based methodologies, transnational indigenous health, and anti-oppression and anti-colonial approaches in mental health. Hence why I said earlier on that it would be a fantastic introduction. So without further ado, I hand the mic over to Dr. Roberta Timothy, and it's an absolute honor for us to be gathered today. If others join, we won't interrupt. We'll just invite them in and hopefully they'll land and catch up. Dr. Timothy, over to you.
Thank you so much, Harry, and thank you so much for inviting me to be a part of the Decolpsych speaker series. So I will be talking today, or my title today is called Decolonizing Your Mental Health Practice Using Anti-Oppression Psychotherapy. What I first want to do is a land acknowledgement. The sacred land from where I speak this today has been a site of human activity for 13,000 years. This land is the territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wanda. Toronto is the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to communicate with you from this territory. I acknowledge and stand by the 94 calls to actions stemming from the ongoing trauma and health impact of the residential school systems laid out by the Truth and Reconciliation Commission, and support the national inquiry findings of, regarding the missing and murdered Indigenous women and girls. I also want to quickly say an Indigenous solidarity statement. I stand in solidarity with the Indigenous peoples of these lands and support their fight for reparations and self-determination, as we know that their struggles are intrinsically related to my people's fight for justice and reparations, as we are linked through processes of genocide, white supremacy, colonization, and enslavement. I vow that even though we have differences amongst ourselves, that the divide and conquer supported, sustained, and fueled by the Canadian and other nation states through systemic oppressions maintained by colonial powers and white supremacist ideologies will not dictate or reconfigure my connection with Indigenous, African, Black, purposely marginalized and colonized peoples locally and globally. I also want to have an ancestral acknowledgement. I honor our ancestors who are intrinsically linked to these lands we inhabit and who fought for their survival. Their lessons and sacrifices have led us to be here today. I invite you to reflect and honor our ancestors, your ancestors, those who have now journeyed, who provide the footprints in which we stand today. I ask you to be aware of your ancestors who you have brought with you today, and ask yourself, what are you committed to learn and unlearn today as we move through this conversation? Ask them allow you to be present, to allow empathetic listening, to be grounded, to assist you in being able to take in the knowledge from me and not have it be erased by the impositions of colonization, white supremacy, misogynoir, and other forms of violence that often erase the voices of African, Indigenous, and purposefully marginalized peoples in our communities. In terms of my location, I identify as an African diasporic woman, African Indigenous, woman of West African ancestry, womanist feminist, surviving African enslavement and colonization, landless, countryless from a working class background, daughter of immigrants via the Caribbean, mother of two, living and resisting with a visual disability in Turtle Island. To be more specific, I have a corneal disorder. I was legally blind at the age of 19 and worked and did all my studies and had 2 corneal transplants in my mid-30s after completing my PhD. I've recently had 2 cataract surgeries and dealing with related complications. I'm letting you know because sometimes, I'm not able to see things, so I wanted you to know that. Also, in terms of my location, I come from a global informed background. I grew up in the feminist movement, anti-violent movement. I was also a part of the Pan-African movement via anti-apartheid. My family were Black activists. Was also part of global indigenous movements. I work with complex trauma survivors in shelters, hospitals, agencies, community health centers, and private practice. I work with children, youth, families, women, men, trans, and two-spirited communities. I've trained and consulted with organizations and practitioners interested in learning and implementing anti-oppression psychotherapy model. I also conduct research. Currently, I'm working on Black Health Matters COVID-19 and other collaborations. This conversation is really to support a conversation about the process of decolonizing therapists and counselors' praxis. To discuss the impact of social and historical context, intersectional violence, colonial trauma, and psychotherapy in a Canadian and global context, and just describe the principles of the model of anti-oppression psychotherapy and the role of transgenerational and transnational connections working with survivors of trauma. I am going to look at a African and Black focus. That's what my focus will be today. However, the model can be used with African, Indigenous, racialized, and other communities, and has been for many, many years. So I just want to give a little information about the Black population. So over 1,198,540 people of African Black ancestry represent 3.5% of the total population in Canada, or Turtle Island. The 5 most Black populated provinces are Ontario, Quebec, Alberta, British Columbia, and Nova Scotia. Brazil, United States, Haiti, Dominican Republic, Colombia, and France have the largest Black populations in the diaspora, and over 250 million African people live outside the continent of Africa, most due to forced migration processes in the past and present. And Africa's population is over 1.3 billion. So I think even utilizing Black population in talking about the Black population, particularly in decolonizing mental health, is a really important community to talk about. I also want to just give some flowers, some shout outs to our ancestors. And I want to think about pre-colonial African folks, and just how did our ancestors deal with mental health before transatlantic slave trade, before colonization. And I want to give a shout out to Kush, to Kemet, to Tobu, to Twa, to Zambi, to Himba, to San, to Ifa, to Hausa, to Songhai, to Khan, Wagadu, Mande, Maje, and many of the classical African indigenous civilizations before Asiatic or European invasion. Some of the practices we still use today, even though often the credit is not given. So I do want to do a shout out to our African indigenous knowledges and mental health practices. I'd like to share a couple of definitions in terms that I think are important to understand the social, historical, herhistorical, and their historical context of intersectional violence, colonial trauma, and psychotherapy in a Canadian and global context. And it's important to understand when using the model or talking about the model of anti-oppression psychotherapy. So I'm going to start with anti-Black racism. There are many definitions, by the way. I always think when we get together, it's really important to have that conversation. What are we talking about? Are we talking about something similar, dissimilar? So I will talk about these couple of these important definitions. So anti-Black racism is racism or racist trauma directed specifically towards African Black people based on the promulgation of colonial violence and sanctioned by eugenics-based racial stereotypes that create particular unjust relationships between African Black communities and white supremacist states, structures, and practices. White supremacy is the ideology and practice that whiteness is equated with dominance and power over, quote unquote, everything, and is a measure by which, quote unquote, everything else is assessed and validated. It describes the unearned privileges that white people gain from the exploitation of African Black people and people of color. I also want to reconceptualize the notion or the definition of violence. It requires conceptualizing violence as any abuse of power, public, private, and structural, that inflicts harm individually or collectively, physically, emotionally, politically, socially, financially, legally, culturally, spiritually, or psychologically. Violence includes the exercise of power to oppress and discriminate against African Black people, indigenous communities, and other oppressed groups individually, collectively, or institutionally based on intersectional multiple identities that can include racism, indigeneity, white supremacy, colonialism, gender, sexism, gender identity, transphobia or trans violence, classism, sexual orientation, homophobia and heterosexism, ageism, disability, ableism, spirituality, religious affiliation, Islamophobia, anti-Semitism, and violence against traditional indigenous spiritualities. Violence also includes immigration status, war, incarcerations, language and cultural appropriation, poverty, educational attainment, legal system, work environment, reproductive capabilities, health and disease control, political governance, be it capitalist or social, resource acquisition, structural adjustment programs, media, social reforms locally and globally, mass genocide historically and in the present in relation to experiences and conditions of forced colonialism and interconnected oppressions within the continents of Africa, North, South, and Central America, Europe, and transnationally. Intersectional violence is the interconnectedness of experience of violence due to oppressions. So, for example, somebody who's experiencing anti-Black racism, misogynoir, and ableism, they're experiencing multiple forms of violence at the same time. The next definition is transgenerational trauma. This is a short one. I actually have a longer one, but I'm going to do the shorter definitions for today. So transgenerational trauma is mental, physical, emotional, spiritual, financial, severe anguish resulting from continuous life-threatening experiences of direct brutality, dehumanization, and extreme violence based on forced African enslavement, colonization, anti-Black racism, and intersectional oppression perpetrated onto generation to generation over an extended period of time. This includes both Africans from the diaspora and Africans who remained on the continent. I also want to problematize resilience. Resilience is being used a lot in terms of mental health, psychology, and even psychiatry. Resilience has been conceptualized as the ability to maintain or regain mental health following adversity, loss, or a traumatic event. It's conceptualized as a trait and as a dynamic process. As a dynamic process, resilience is seen as a multi-dimensional characteristic that is the result of context, time, age, gender, culture of origin, and other specific life circumstances. Our critique is the way that resilience is discussed does not address the social historical realities of intersectional violence and colonialism. The narrative of trait is predominant. We like to use in our model resistance. Resistance is the struggle to survive, exist, persist, and try to eradicate ideologies and practices of colonialism, anti-Black racism, anti-Indigenous racism, classism, sexism, heterosexism, and all other forms of intersectional violence or oppression or trauma in African, Black, and Indigenous people's lives as emancipatory acts. I also want to quickly define drapetomania, particularly as we're talking about decolonizing mental health. Drapetomania was a mental illness disease of enslaved Africans, quote unquote. It was considered a psychological disorder which induced Africans to run away. That was the disorder. In 1851, American physician Samuel A. Cartwright hypothesized as a cause of enslaved Africans fleeing captivity, and the treatment was whipping. And I think it's really important to understand when we're looking at the history and herstory of psychological disorders, psychiatry, mental health, that the anti-Black racism and the intersectional violence that exist and existed within the context of even of the creation of these disorders, and then also in supporting the continuation of colonization and justification for enslavement. So I'm going to now do a brief review of the importance of decolonizing mental health and mental health research, and then I'm going to get to the model. I want to start with a quote from one of, I would say, my countrymen, as I have family who are also from Martinique, Frantz Fanon, the great Frantz Fanon. Imperialism leaves behind germs of rot, which we must clinically detect and remove from our land, but from our minds as well. And I want us to think about that as we move through the presentation. So just looking at a brief anti-Black racism context transnationally, over 500 years of colonization of African Black bodies, Indigenous African peoples have experienced genocide, African enslavement, the independence movements, Pan-African movements, the rise of the elite classes, civil wars, forced migration, immigration, incarceration, all the context of colonial violence and the context of colonization, forced religion, demonization of African spirituality, demonization of sexual orientation, incarceration of disabled, and it's incarceration of Black community members globally, violence through rape, physical, emotional, environmental, financial, educational, torture, transgenerational trauma, and health violence is the impact or the result. Legacies of colonization on African descendants, disparities in health, education, and living conditions, racial profiling and increased incarceration, ongoing anti-Black racism, segregation, over-exemplification of Canada as Underground Railroad, internalized oppression, white supremacy, and anti-Black racism are all results of the legacy of colonization on African descendants. Some important factors to understand when we're looking at the impact of colonial violence on Black peoples and mental health are again looking at the role of violent family separation from Africa, forced from land and family, role of the Middle Passage, role of brutal enslavement, criminalized identity, traditional African name change, languages forbidden, education forbidden, forced from land and family, role of Darwinism, eugenics, role of patriarchy, witch hunts, etc., role of psychiatrization, the creation of the doctor, no longer medicalization of health and mental health, the role today of anti-Black racism and intersectional violence endured on a daily basis, and health violence as a result of continued colonial violence. Just want to say just a couple of factors of what's happening in Canada, and I want you to think about the impact on mental health when I'm mentioning a couple of these examples. So in terms of reported hate crimes, and these are hate crimes that were reported to the police, race and ethnicity, we have the highest numbers in the Canadian context of hate crimes against people based on race or ethnicity, and Black African folks, identified folks, are the number one folks who have experienced the most hate crimes in Canada. And we know that the impact of dealing with anti-Black racism and dealing with colonial violence is our mental health issues and mental health problems, and also creates these mental health stigmas. So kind of the continuation of colonization within the Black community has created these mental health stigmas and myths. Some of them are Black people can't seek mental health services, depression and anxiety is a white people thing, the notion of superwoman and superman, crazy and mad people seek mental health supports, mental illness means you didn't make it or you failed yourself and family, and Black people do not seek mental health services. And I want to say these myths are connected to colonization. As a practitioner who works with Black, Indigenous, and purposely marginalized folks, Black folks come to therapy, they come to mental health services, but they often do that in secrecy or in private, not wanting to share with folks their experiences. And based on the stigmatization of African Black peoples, we can understand why that happens. But I do want to challenge the myth that African and Black folks do not seek therapy, because they do or do not seek mental health or wellness processes or wellness and healing ways. I want to now move on to why decolonize mental health. So I talked a little bit about the context, the pre-context and the context of colonial violence, and I want to talk a little bit about why decolonizing mental health. Anti-Black racism is a central determinant of mental health. Anti-Black racism is activated with other forms of intersectional violence in the lives of African communities. The impact amounts to complex traumatic experiences for which specific anti-oppression interventions are required. Mainstream psychotherapeutic approaches need to integrate an anti-colonial or oppression perspective. Transgenerational trauma and mental health is a cumulative violence from transgenerational and transnational traumatic experiences, the legacy of enslavement, colonization, the underdevelopment of Africa, the cumulative violence from mental anguish due to transgenerational and transnational traumatic experiences, known or felt or experienced, perceived explanations of violence, genetic changes, for example, and health adaptations as a result of ongoing and persistent trauma. For example, diabetes is connected to the colonial histories and colonial violence. Psychiatrization and continued depletion or robbery of resources are all connected. And anti-racism practices lessens harm, trauma, and violence. It allows people to really do social justice change work needed to support and to foster real healing and wellness for African Black peoples and purposefully marginalized folks. The importance of decolonizing mental health is to learn and unlearn the connection between mental health and colonization, to reflect on the impact that colonial practices of mental health have had on ourselves and our communities, to understand the fight for Black mental health for African Black communities as a movement to dismantle the quote unquote master's house, resisting mental health, intersectional violence, and mental health stigma as a tool for healing is important, and it happens through decolonizing mental health, and healing the impact of transgenerational trauma by using culturally appropriate mental health supports. We need to imagine what can Black wellness and Black healing look like. For mental health practitioners, why anti-racism and anti-oppression practices, why decolonizing is important to support it, to decolonize your practice is important, is it supports the empowerment of your patient and your clients. It lessens harm to community members, workers, clients, patients, and their communities. It can get the fuller picture and case history of client needed to support them. Emancipatory building that impacts individuals as well as their and your communities. It supports real holistic care and strength-based healing work. It reduces working in silos, understanding and participating in anti-racism, anti-oppression work. Example, social justice advocacy and policy change is also required. Our response to transgenerational and transnational trauma in making trauma-informed accountable to our communities is the development and practice of anti-oppression psychotherapy. The principles of the model of anti-oppression psychotherapy and the role of transgenerational and transnational connections working with survivors of trauma are all revealed in our model. It's a trauma-informed care model from an AOP, from an anti-oppression psychotherapy approach that focuses on decolonizing mental health. Trauma-informed care recognizes that individuals and their communities have experienced, and in many cases continue to experience, violence daily directly related to colonialism, anti-Black racism, transnational and transgenerational trauma, and intersectional violence, among other factors. As such, addressing the impact of oppressions on the lives of individuals and their communities, including service providers and practitioners, is critical to reducing re-traumatization, dissociation, and harm. Physical, mental, and spiritual distress based on continued exposure to violence leads to traumatic stress that needs to be supported with culturally responsive, decolonial-centered practices and resistance-based healing approaches. That's anti-oppression psychotherapy. It challenges problematic aspects around trauma theories and praxis. The silencing and pathologizing of survivors that often happens with mainstream models, the ahistoricalness, Eurocentric colonial perspective, only certain traumas are publicly recognized as such, the psychiatrization, the connection to intersectional violence, the blaming the victim, economics behind evidence-based treatments, effectiveness versus efficacy, re-victimization are all addressed within this model. If we look at the basic mainstream psychotherapy model, we look at the therapist, the client, and the importance of creating therapeutic alliance. And the context in which the psychotherapy takes place is an alliance exists with transnational social historical context determined by social and structural relations. There have been multiple calls, Fanon, Duran, Bonzai, Van Neer, Cole, for a change in the predominant Eurocentric colonial and androcentric paradigms in counseling and psychotherapy. And a shift is necessary. It requires a shift towards frameworks that take into consideration contextual power dynamics based on dimensions such as race, socioeconomic status, gender, indigeneity, age, and sexual orientation, among others, moving beyond one-size-fits-all approaches. From a health promotion perspective, it involves a comprehensive integration of a perspective that addresses the social determinants of health. Anti-oppression psychotherapy is a therapeutic approach that therapists and other clinical practitioners can use with clients to support an empowerment-centered change process needed to deal with the effects of oppression, trauma, and intersectional violence in clients' lives. AOP incorporates both anti-oppression theories and practices and psychotherapy to understand and work with individuals and our groups under internal and external distress due to the lived experiences of oppression, trauma, colonization, and intersectional violence. By examining the impact and experiences of clients' locations and identities, clients and therapists' relationships with transnational and transgenerational contexts, and clients' experiences of intersectional violence, AOP can provide a catalyst for change in the lives of clients, therapists, and their communities. The actualization of resiliency, and more importantly, the move to resistance for clients and therapists to an integrated psychological change process is critical in AOP. I'm now going to there's some case studies, but I'm not going to go through them right now. But if people have questions at the end, maybe we can talk about some examples. I want to go quickly through the principles, and then we can end for today. Principle 1 is dedication to addressing intersectional violence and oppressions in the therapeutic process. Examining and building clients' and therapists' anti-oppression or decolonial competencies is critical. Acknowledging and respecting different worldviews and knowledges is essential. Psychoeducation on oppression, anti-colonial, and anti-oppression praxis is necessary. Principle number 2 is in AOP is understand that systemic oppression and practices of exclusion contribute to trauma and violence of the body, mind, and spirit. Experiences of oppression determine mental health. AOP provides innovative coping techniques and tools to relieve distress and stress of oppression on the body, mind, and spirit. Principle number 3, examining and determining clients' and therapists' identities is central to AOP process. And we look at within principle number 3, identity trichotomy in psychotherapy. And there are 3 aspects of the identity trichotomy. 1, fixed notions of identity. 2, different notions of intersecting identities and oppression. And 3, therapeutic alliances, negotiations of understandings, and using identities for change. The first tenet, fixed notions of identity and trauma, or what we call the box. The first tenet requires therapists and clients to explicitly examine the impact in clients' lives of fixed notions of identity. Fixed notions are essentialized, categorized, or stereotyped, discriminatory, and prejudiced views prescribed by individuals, groups, or institutions that sanction systems of oppression and practices of exclusion. Fixed notions of identity are usually created to limit the access of certain people or groups to various mainstream services and or resources, example to healthcare, education, or social supports. They produce fabrications of otherness, where people are separated as outside of and none deserving, quote unquote, or as uncivil, quote unquote, and or worthless. These fixed notions generate misleading explanations for physical, sexual, or emotional abuse. Therapists and clients must address their own fixed notions of identity and trauma, both in their own lives and their clinical settings. Only then can the therapeutic alliance foster empowerment. There are some key questions that are asked, but I'm going to just continue because that might be a little bit too much. Tenet number 2 is different notions of intersectional identities and trauma. After deconstructing and challenging fixed notions of identity, therapists and clients examine their intersecting identities and experiences of intersectional trauma. Tenet 2 invites therapists to talk to clients about their experiences or stories over time without interpreting them and judging how the clients might feel or act. The therapeutic interaction acknowledges how clients may experience multiple oppressions and violence, as well as their own specific experiences with others based on their intersectional identities, race, indigeneity, gender identity, class or socioeconomic status, sexual orientation, disability, age, and spirituality, to name a few. It provides a framework that accommodates the particularities of the individual's unique and collective experiences. Tenet 3, strengthening the therapeutic alliance through negotiating, understanding, and using identities for change. All of the tenets are powerful, but this is a very powerful change process when this happens within the therapeutic relationship. When therapists engage clients in an active dialogue, the process helps clients to reject fixed notions of identity, create their own notions of community, and consider how they can make changes in their lives by reconfiguring notions of who they are to reflect more fluid and more reaffirming aspects of their identities. This process is particularly important as it interprets clients' prescribed notions of being quote unquote hopeless, isolated, and victimized. Instead, they form new understandings of their belongings to different communities that have resisted intersectional trauma historically and transnationally. By this stage, the strength of the therapeutic alliance and the coping skills clients have cultivated can help them resist intersectional forms of trauma and violence in their lives. Principle number 4, understanding dissociation and re-traumatization in the therapeutic process is critical to AOP. The out of sight, out of mind. AOP interrupts the out of sight and out of mind practice by engaging clients' experiences of intersectional violence to support their healing. This is a sharp contrast with the prevalent out of sight or out of mind approach often found in mainstream psychotherapeutic relationships due to therapists' inability to understand or the devaluation of clients' experience of intersectional violence and the impact of colonization. There's multi-location and multi-understandings of systemic re-traumatizing that happens. And the healing metrics is a way to help clients process healing in a space where trauma still exists. The fact that colonization still exists and we're still trying to decolonize our mental health, wellness, and healing happens through the healing matrix. The healing matrix illustrates the extreme difficulty of the healing process when intersectional violence is uncontrollable and reoccurring daily in clients' lives. Prevailing systemic conditions create ongoing experiences of oppression that can re-traumatize clients at any moment during the therapeutic process. The AOP therapist must support clients to process their experiences of intersectional violence to lessen dissociative or fight-flight reactions. More importantly, though, therapists need to assist clients to correlate and understand how their dissociation functions during repeated experiences of violence to assist in the development of coping skills. For example, I'm going to give one example here. For example, consider a Black client dealing with depression who was doing well and arrives to the next session traumatized after being followed and harassed by security in a local drugstore right before session. The connection between her depression and experience of racial profiling needs to be addressed in session, for which the therapist's validation and witnessing of her experience of intersectional violence is vital. Moving from chaos to cooperation and communication is also important for this principle. Moving from chaos to cooperation and communication is a process that enables the client to process their dissociative responses by examining and communicating about different and complex intersectional identities and experiences that have resulted from prolonged exposure to intersectional violence, stress, and trauma. Cooperation and communication as an approach should not try to force or rush to dismantling or connecting the dissociative response or quote unquote integrate these elements of intersectional identities and experiences, as dissociation is already interrelated. Principle number 5, locating clients and therapists framework historically, and geographically, locally and transnationally based on intersectional factors. It's exploring the connection of clients' distress in transnational and transgenerational contexts, the connection of transgenerational trauma on the therapeutic process is very important here. The questioning the here and now, the interrogating the multiplicity and power dynamics behind the here and now. Whose here is now and now is represented? What exists in the here and now? Who historicizes? Who historicizes? What is here and now? What is not here and now are all looked at. The transgenerational, transnational, local connections. Principle number 6 is engagement in emancipatory empowerment-centered change process with both client and therapist. The change in therapeutic alliance requires deconstructing and challenging of internal and external views and practices of oppression in relationships. Principle number 7 is accountability and responsibility. Client and therapist in anti-oppression psychotherapy are accountable and take responsibility regarding implications of location. Critical, how do you as a therapist participate in the perpetuation of systemic oppression and violence? In anti-oppression psychotherapy, therapists engage in personal work to deconstruct notions of oppression. And this is through a process of methodology called resistance education. Principle 8, which is the last principle, is resistance and resiliency is critical in the AOP process. The therapeutic process takes place beyond the therapy session. Client actualizes change on a daily basis through processes of resistance and resiliency. Therapists support clients utilizing resiliency-centered tools and resistance-centered tools to actualize change in clients' lives and their community. An evaluation of prior and learned resistance tools of client and therapists are critical to this process. Anti-oppression psychotherapy facilitates a process of deconstructing using intersected and fluid identities for change, practicing resiliency, resistance, and finally identifying, strengthening resistance strategies to all forms of intersectional violence. Resistance is not looked at as overcoming, but rather as nonlinear processes and resources valuable for dealing with the unpredictable nature of daily experiences of continued stressful and traumatic intersectional violent experiences. It provides clients with tools to support and reduce stress while enabling them through strong identity associations and resilient actions to cope and live in a climate that is violent. Exploring, this is a summary of AOP that I hopefully we can have some questions. The summary of AOP, exploring clients' identities along with the experience of intersectional trauma, transnational and transgenerational connections and resistance and resilience lessens the potential for re-traumatization and increases the opportunity for empowerment-centered, safer mental health practices. Understanding intersectionality is critical to gaining holistic insight into the lived experiences of clients and to lessen the biases and stigma that often occur when clients are looked at from a single or monoculturalistic lens. This encourages clients to engage in a collaborative change process with the therapist, which strengthens the therapeutic alliance. The major tool in facilitating in an AOP approach is you. I invite you to be part of the revolution and help change and dismantle the notions of inevitability of transgenerational traumas hold on the healing and wellness of resistance-centered communities. AOP Lens enables the whole picture of clients' distress trauma to be known. Using this wider lens, the therapist can better support the client from an anti-violence, decolonial praxis and lessen the chance of them being traumatized. Using an anti-oppression framework, the therapist encourages the client to explore who they are holistically, recognizing or including all aspects of their experiences so she can feel greater safety. At the same time, the therapist is aware of how her own personal experiences and social locations may facilitate or strain the therapeutic interactions with her clients. I want to end with a quote from Audre Lorde. When I dare to be powerful, to use my strength in the service of my vision, then it becomes less and less important whether I'm afraid. Thank you.
Thank you. How amazing. Thank you, Dr. Timothy, and thanks everyone for being here. Roberta's happy to take questions. Sometimes we suggest that we don't necessarily think of it as a linear thing where you ask the speaker a question. We can have a conversation, particularly when we've got an intimate group like this. So feel free to pick up the threads of anything you've kind of heard a previous contributor say, and yeah, let's kind of keep it fluid. So is there anyone who has a comment or a question right now? Whilst you formulate whatever's perhaps bubbling away for you, I just kind of wanted to just say a couple of things by way of observation. I think what was really striking, and really thank you a lot for this, Roberta, was the kind of recognition that though we're talking about anti-oppressive psychotherapy, there's an acknowledgement that what is being spoken about isn't just what's happening in the room, but that it isn't just an emotional state, that there are material inequalities and impacts, and it isn't just what's happening now, that we can kind of look back through history and see the imprint of transgenerational trauma in people's lives and in the cells of their bodies, and that kind of comes into the space too. And I thought that was very salient to me. And I guess the thing about validating people's experiences, that I guess psychotherapy that doesn't take account of those lived realities of people is in some way invalidating their experience, because the silence kind of suggests a belief that it either isn't there or that it isn't pertinent. So I kind of thought that kind of came across very much in accords very much with the work I do around toxic interaction theory, and how that non-validation can be toxic despite the practitioner not meaning to cause harm. It is actually very harmful to be silent on something which is so pernicious and pervasive in the lives of people with whom we work. So I kind of just wanted to say that by way of summary. Thank you, express gratitude to you for bringing those things into our space. So back to yourselves, others in the space, really welcome your reflections, questions, or any other contributions.
I also would like to say, like, how are people feeling? You got a lot of information. I obviously went through the 8 principles very quickly, which I have, we occasionally do. But how do you just feel? How is it landing for you? how are you thinking about your own practice or your own place of where you're at? Those are the kind of questions I think are important to look at. Tori, hello.
Hi,
Hi.
I wanted to say thank you. I'm formulating very slowly, but I first formulate with gratitude and with also with slowness. It's a learning space for me at a very deep level. What am I thinking and how am I feeling? I'm thankful for the depth that you're taking us to with everything you're bringing, and I'm looking forward to also watching this again so I can take in more. It's important. Hey, I suppose the other thing I'm wondering about, I'm in the UK. And we talk about trauma-informed care over here. Harry, you'll know this a lot through something called NHS Scotland's vision and their model and their framework, which what I'm thinking about right now and how I'm feeling right now is something I've been feeling all along, which is there's a discussion about these six principles of trauma-informed care, and all of the things that you spoke about are consolidated into one principle called culture.
Mm-hmm.
And I'm mystified by it, really. And that's all. That's what I'm doing. I'm just mystified by that because it doesn't cover it. It doesn't cover racism. It doesn't cover transgenerational trauma or racial traumatization or gender or ability. It's just called culture.
Right.
How does that land for you when you hear that?
I think that's such an important point, and you know, trauma informed is a model that you know has a more recent history or history, right? But it's being used. It's being used all over the place, and I think the context of defining something with culture without talking about the real impact of colonization and the real impact of different intersectional violence is pretty problematic because there's no accountability, right? We're not culture does not explain the accountability for what has happened in around the world in terms of mental health distresses based on colonization and other forms of violence or brutality. Culture, it's even culture. We think of culture. I think of culture like for the culture. You know, it's like I want to eat something. I want to eat some food. I want to share some, you know, some fun times with you. And I think it needs to be described in a way that actually makes sense for the communities that are impacted. And when I think about the impact of anti-Black racism, of transphobia, of ableism, of misogynoir, you know, I'm not thinking of culture. If I'm thinking about culture, it's cultural violence from you know other nations onto African bodies. If I'm talking about the African Black population, so I think these are things that are often used not to actually talk about the roots of the problem, and it actually not having a social historical or the historical context is it's I'm frightened by that when we're doing trauma informed work. How can it lead to the honest experiences and stories and hopefully supporting people in healing and wellness when we actually can't even say the words in terms of what has happened for folks' lives in terms of intersectional violence and oppression? So yeah, I think that'd be a great. Maybe there is a paper in UK. Let me know. Maybe you guys are writing one. But to really deconstruct that notion of culture, I think is really important. But it does happen here also in different ways, and it doesn't help for help folks who are suffering from generations of trauma. Yeah.
Thank you. I also just one more thing. I agree about a paper. I wonder further about a campaign because this is damaging.
Yeah.
Just a question, maybe for the website to raise. Thank you.
Thank you, Tori. Yeah, I'm all into campaigns. I've been on the I've been an activist for a long period of time, and I think I said a paper. I think that's my soft way of saying what I want to say. But I think it's like how do you actually challenge some of these processes and policies, particularly when they're statewide or nationwide or region wide. It's not, these are not like it's not a little organization. I'm hearing it's from the government or nationally, or this is part of a national agenda. Then there's ways that can be challenged and should be challenged, I think.
I just say I agree with you on the paper, absolutely agree. And language and words and that it begins with that, and then like let's take it further. Yeah.
Thank you.
Thank you.
I also want to address something that Harry said earlier, like when you talked about therapy moving from, your folks' daily experiences, our clients, our patients, our own experiences. I always think like I don't move myself from, folks in terms of my own mental health, my own transgenerational trauma. As a survivor of enslavement and colonization, I'm also, I'm also a patient. I'm also a client, or have been at different places and spaces. That's one thing I do want to say also. And it's what was happening on a daily basis, my own life and our clients' lives, is that folks were, they had the most amazing session, as you know, right? We had a great session. Yay, we did some breaking work. It's been months, it's been years. And then something would happen. And what would happen was the example I gave you is somebody being followed in the store, or they were fired at work, or somebody's, said a really racist or homophobic or ableist or classist thing to them. And they would, their healing process would stop. They would go back into distress moments and, really wanting to create a model that actually addressed that we're there for an hour, sometimes 2 hours, for weeks, months, years, depending on who it is. But how do we actually empower our clients to, to deal with the onslaught of trauma and violence that they don't know what's going to happen on a daily basis. Even myself, I had a great session. Yay, it's great. I'm wonderful. I walk into a store and I'm followed, right? And I have to deal with that, the experience of anti-Black racism and profiling. What do I do? How does that impact my healing and my wellness? So we really have to look at our therapeutic experiences, or the gift of being with folks, I think, in their healing process, as also really social justice practices. Like, how are we changing the world? Like, what do you do as a therapist or clinician? I'm not just, talking about decolonizing mental health in my office. It's something that I walk with, talk with, and actualize on a daily basis, 365, 24/7, with rest, of course. So yeah, I just wanted to really stress that piece in the model. And we've trained many folks. We trained about over 500 folks in different aspects of the model, and people. Then we clinically supervise and support people in the model. And right now we're creating a longer training program, so we can actually train folks as therapists to be certified, and certified as anti-opression psychotherapist model. I do want to say one thing too. It was actually a lot of the theories and actions and experience and lived experience and knowledge that came. I worked in the shelter movement, anti-violence movement, for many years. My mom was a shelter worker, and was involved in a lot of Black activist and activist work. And it was actually called anti-colonial therapy. And I want to say this because it was, and folks were not ready for anti-colonial, decolonial. They weren't even ready for anti-oppression. Like, the words scared folks. They're like, Roberta, you're not, like, how are you living? How are you planning to practice this? And it was the words, it's interesting now, anti-oppression is still not used often, but it's used more than it was. But it really comes from a decolonial or anti-colonial Black feminist framework. That's the roots of this model. And it's used with all types of clients who have different intersectional identities. Yeah.
Thank you. Thank you, Dr. Timothy, and thank you, all of you. It's been really, really splendid. It kind of, we speak about the website, Decolpsych, being this reservoir of rich material, and it kind of feels like we had a taste of what it can be like with this kind of real density of knowledge and, all these different threads of thought and connections in what Dr. Timothy presented to us. It was so amazing for me, how much, and I can kind of really accord with Tori and the idea of going back and listening again, and just seeing how many layers there are that we didn't grab hold of. So thank you, Dr. Timothy, for sharing so kindly and with such insight. Really appreciate that. For all of you, enjoy the rest of whatever is in your day or your evening. And the recording is available for anyone who's booked on here. And please do visit decolpsych.com. And also, if you feel minded to make any contribution, we'd really welcome that. And that could be content, but it could also be money. If you wish to donate to the website, yeah, please feel free to contact us.
I just want to add one thing, Harry, just one thing. There's 2 articles out that you can get online for free about the model. So please, I after I speak, I'm always like, what? Let me go back. So please look at those articles, and you can ask me and I can send them to you also. to add to the learning and unlearning process. Thank you so much.
How do we get them? Sorry to interrupt. How do we get them? Yes, please. I'd really be grateful.
I'll send it to Rebecca. I have your Rebecca, and I have Hari. I have your email, so I'll send it to them, and then they can send it to you.
Fabulous.
One quick question. Thank you for that. Just about the quote from Frantz Fanon. What was it you said? Imperialism leaves behind ... I couldn't get the whole.
Gosh, I don't remember. I don't
Okay,
remember my
just send
quote, but it's imperialism leaves behind germs of rot, which we must clinically detect and remove from our land, but from our mind as well. And I can send you that quote with the information. Yeah, definitely.
Fabulous. Thank you. Thanks, everyone. Please do stay in touch if you wish to do so. Thank you to Rebecca for getting us on track and ensuring that everything was set up for us to have this session. Thanks. Have a really great evening.
Thanks, everyone.
Thank you. Take care.